So welcome to the afternoon symposium. I think that we will get started. The title of our symposium is Every Way of Seeing is a Way of Not Seeing, Critical Insights into the Blind Spots of Entrustment Language. My name is Dan Schumacher. I'm at the Cincinnati Children's in the United States. My co-presenters are Lorelei Lingard at Western University in Canada, Anneke van Ink at the University of British Columbia in Canada, Karen Hauer at the University of California, San Francisco in the United States, Carraccio at the American Board of Pediatrics in the United States, and Olle and Cate from the University of Medical Center Utrecht in the Netherlands. We will first present some individual things to you in the order here, and then we will engage all of you in what we hope will be a lively interactive discussion. So what do we mean when we say entrustment? If I don't entrust you to do something, does that mean that I don't trust you at all to do anything? What if I'm more likely to entrust you than someone else? What if I'm less likely to entrust you than someone else? Does the language of entrustment even align with how medicine is practiced and how training carries out? How do the answers to these questions and other questions inform how we make decisions around graduation using entrustment as a framework, or other critical sort of thresholds that we would set during training? We will explore these and other questions in this symposium, really with an eye for what are some of the blind spots of entrustment language that can trip us up. We will begin this exploration with Professor Lorelei Lingard.
Good afternoon, everyone. Thanks for joining the discussion at this symposium. Entrustment is a word and a concept that has risen to enormous influence, popularity, and power in the last decade and a half or so. And underpinning this concept of entrustment is a whole set of terms, evolving, rather fragile. We all use these terms interchangeably sometimes. We use them for our own purposes. We use them in different ways in frameworks than we do in empirical work. This matters because the language of entrustment is not only something we use to describe our world. The language of entrustment is constructing our world in medical education. If you were in medical education 15 years ago, you know that this language didn't exist. And as a consequence, performance, competence, assessment, expertise were all constructed differently than they are now that we're doing that construction with the language of entrustment. This idea that the language of entrustment is not only descriptive, but also constructive, leads to our focus in the symposium. Kenneth Burke is one of the most prominent rhetoricians of the 20th century, and he was interested in how language shapes not only the way we describe things, but also the way we think about them, and as a consequence, the way we act in relation to them. And one of my favorite sayings from Kenneth Burke, and obviously it's in our title, we're hoping if you leave with nothing else, you'll leave in possession of this lovely saying. Kenneth Burke said that every way of seeing is a way of not seeing. He recognized, as did many language theorists of his era, that the world is too complex for us to take all of it in. And so we use language as a way of organizing, focusing, as a way of selecting some things for the foreground, some things to attend to, and deflecting other things, putting other things in the background. So every time we make a choice of language, we are selecting and deflecting. We're creating emphases of attention, and we're creating what he called blind spots. Now, some forms of language accrue such power in our worlds that Kenneth Burke calls them God terms. And we wonder whether entrustment is attaining the status of a God term. A God term is a word that has such power that it subordinates other words in a conversation. You play it as a kind of a rhetorical trump card if you want to win an argument at a clerkship committee meeting or something like that. So we're wondering today whether entrustment has become a God term, and if it has, what are the implications for the ways that we use it? So our objectives today, as Dan already briefly outlined, are threefold. We would like to expose some of the blind spots of entrustment language. We would like, in doing so, to illustrate the inherent complexity of entrustment language as a basis for making decisions, high-stakes decisions about clinical performance. And we also would like to reflect, discuss, perhaps advocate for a shift in our vocabulary and our lexicon around entrustment. And I have the honor of going first. Those of you who know me know that I have spent over 20 years studying how teams work together, how they talk together, how they collaborate, and I do a lot of writing and stomping my feet about this thing I've called collective competence. So you won't be surprised to know that the blind spot that I want to spend a few moments discussing this afternoon is the blind spot of interdependence. In order to do that, I want to start with a quote from Mark Twain, who said that it ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. Let's look at some of the really key texts related to entrustment. I've selected this one by Cate and Olle from 2007, in which they define entrustable professional activities. And I have put in emphasis in that definition one of the dimensions, which is that an entrustable professional activity should be independently executable. If I had 10 minutes, I would show you a whole raft of publications which take up this notion of independent performance as what we are entrusting. But I only have time for one. I've taken this from the Royal College of Physicians and Surgeons of Canada, from their online set of resources to support competence by design. Here's their definition of an entrustable professional activity, where you see again this notion of to perform independently, that an individual performs something independently that we can entrust. Now, why does independence get foregrounded in the first few slides of my talk? Because I would submit to you this afternoon that independence is what we know for sure about entrustment that just ain't so. I'm going to draw on two of our research projects to sketch this in a little more detail for you. My colleague Stephanie Seebach-Sire and I led a research team. This work was presented last year at AMEE, where we were interested to know if we are entrusting independent performances, can faculty and senior residents tell us what those performances are in the clinical setting? And so we interviewed a series of faculty and senior residents from 12 different postgraduate specialty programs. And we asked them, what do residents do as independent actions and decisions that you can assess and entrust? And while they could give us some independent examples, the interviews were largely characterized by their explanations for why even those were really not so independent. We described a model of what we called coupling to try and characterize the strong relationship between what a trainee does and their faculty supervisor. So coupling between trainee and faculty, coupling between trainee and other members of the healthcare team, other learners, other healthcare providers, and coupling between the trainee and the system. So for instance, an obstetrics gynecology faculty would say, well, the resident may deliver the baby, but they're not doing it independently. I'm engaged in that with them, even if my hands are not actually performing the delivery. Interestingly, even when our participants talked specifically about entrustable professional activities, they talked often about how those are interdependent performances, such as an EPA of informed consent. This is a faculty member from internal medicine who's describing that informed consent is a performance that's actually largely led by the social worker in their clinical context. And so when they're entrusting senior residents, they're not entrusting them to do the task. They're entrusting them to interact appropriately with the social workers in doing the task. We, like others, have become quite interested and kind of enthusiastic about the possibility of giving residents feedback on their clinical performance by drawing on data that's already in the electronic health record. We focused on emergency medicine, and what I want to use this particular study to describe today is to show you how there seems to be a spectrum of independence and interdependence in most of the resident clinical performances that we are now using to gather from the EHR. So in this particular study in emergency medicine, we started with the indicators from the faculty's clinical report card, which they get regularly as a QI initiative in the hospital. And we asked faculty from Emerge and senior residents if they could please tell us which of these clinical performance indicators were relevant to residents, and were they independent or interdependent performances. This table is organized from top to bottom, those clinical performances that our participants saw as most independent and those that most participants saw as interdependent. So for instance, you can see at the top that the turnaround time between when a resident signs up for an emergency patient and when they submit their first orders, that was perceived to be an independent performance, a reflection of them as an individual and their competence. But go all the way to the bottom, the length of stay, all participants said, that is not on me. Length of stay is an interdependent clinical variable. It's the middle of this table that is most intriguing and is starting to push our theoretical thinking around interdependence at the moment. The more darkly shaded gray the row is, the more there was variance in participants' assignment of that as an independent or an interdependent performance variable. So for instance, there is some real interest in gathering data about residents' test ordering as a kind of a health services monitoring practice. But here you can see that about half of our respondents saw that that was independent and the other half said no. What kind of test ordering practices a resident has is an interdependent performance. So this is partly in the eye of the beholder. It partly depends on year of training. It partly depends on clinical context, etc. My last point is this. What does this particularly have to do with entrustment? Let's look at time to fluids. In emergency medicine, the first transition to discipline EPA in the Canadian postgraduate program is the ability to recognize and stabilize a critically ill patient. For instance, a patient who arrives at the emergency department with sepsis or shock. There is a clinical guideline that indicates the time from recognition to administration of fluids and tells us, using a validated benchmark, this is how long it should take you to get fluids into that patient. But you see here that our participants, 84% of them said this is actually an interdependent performance, and yet it is the first transition to discipline EPA, which is defined as an independent performance. My message this afternoon is actually painfully simple. Entrustment language assumes an independent performance. And yet experientially and increasingly empirically, we know that clinical performance is interdependent. So I submit to you that we need to renovate our entrustment language so that that assumption of independence doesn't seep into our attitudes and actions when we're entrusting our learners. Thank you.
So my blind spot picks up right where Lorelei leads off. And so she proposes to us that we strike independent practice from our vernacular, perhaps. So if we do that, what is our next option? Well, some entrustment frameworks are now using the language of unsupervised practice, which is perhaps what people do at the end of training. They are not supervised any longer. But even this can present some problems for us. So I'm not sure that we live in the day of the old country doctor anymore. We talk about supervision and we pit it against autonomy as if they are opposite ends of a spectrum, where the goal of training is to move from supervision during training to autonomy, by which we mean not being supervised at the end of training. However, I'm not so sure that this conceptualization of supervision and autonomy is not outmoded, and maybe was never correct in the first place. I think that the optimal clinical learning environment is one in which trainees are given autonomy while they're being supervised. Like this trainee here, who's performing an endoscopy procedure while her supervisor is watching on, while she is actually doing it. If we lean into how these can coexist, we need to pick a different definition of autonomy than not being supervised. And I think that self-determination theory gives us some help here. Self-determination theory posits that autonomy is allowing someone to act of their own volition. And self-determination theory also posits that this is an innate sort of quality that makes people want to learn, allowing them to act of their own volition. So I would argue that we lean into that definition, because if we do lean into it, even a very inexperienced learner who requires a fair amount of supervision can be given autonomy, can be allowed to act of their own volition. Think about a medical student who's on an inpatient rotation. They can make choices about which patients they primarily provide care for, or they can help make decisions about what they're going to learn that aligns with their future goals and their interests. If we don't lean into how these can coexist, how supervision and autonomy can coexist, and instead we see them as polar opposites, I think that we're creating a blind spot for the ability to really provide learning environments that are optimal for residents.
Good afternoon. I'm going to switch from focusing on specific terms about entrustment to a linguistic tool for entrustment. And I come to this blind spot of trusting the entruster with a background in applied language studies and an interest in how the knowledges of different stakeholders in medical education are and sometimes are not recognized. So entrustment as an approach to assessment was conceived as a way of recognizing an assessor's holistic judgment of learners' abilities. But in looking at the language of entrustment, and by this I mean not just the texts, but all the surrounding practices and other related texts to that, I've begun to wonder about the extent to which we really do trust the entruster. So entrustment scales ask assessors to record their answer to this question: to what extent do we or I trust this learner to perform this professional activity without supervision? And there are variations of this scale. The common one is the generic scale that's documented by, I think, Cate and Schele, the 5-point scale. And these scales are intended to be, or are, embedded in the documents and practices that make up formal assessment practices at an institution. Scales like the one on this slide might be used prospectively to register a decision about the level of supervision a learner requires going forward. Scales might also be used retrospectively to document what kind of intervention a supervisor felt was needed while observing an activity entrusted to the learner. And you'll see an example of a retrospective scale in just a moment. Scales are typically concise, but they can be accompanied by other types of information, and they can also be used in conjunction with other forms of evaluation. Typically they are. Now, the current tools of entrustment are relatively early iterations, and the entrustment scales now in use will no doubt be further developed. But as we move ahead, one question I want to suggest will be important to ask is, to what extent do we trust the entruster? More precisely, to what extent do entrustment scales, and of course the broader context of assessment-related texts and practices in which they're embedded, reflect the trust that we place in assessors' subjective judgments? That might seem a surprising question, given that entrustment was conceived as a means of tapping into assessors' broader expertise. Entrustment was meant to acknowledge that an assessor's subjective judgment offers a holistic perspective, taking in dimensions of learner performance that cannot be captured by a checklist and not even always by written comments. But formalizing entrustment, which entails codifying it, presents challenges. This is particularly so in an assessment culture that has long privileged objectivity as the best way of ensuring validity and fairness, and that has developed linguistic tools accordingly. With the embrace of CBE and its emphasis on clear definitions of outcomes, we continue to privilege objectivity. We foreground what is empirically perceived and logically understood, and we insist on its linguistic expression. In fact, if the knowledge cannot be rendered explicit, its legitimacy tends to be suspect. Now, the explicit form that CBE tends to take has been a focus of critique, of course. Typically, we see competency checklists that fragment the activities of learners into analytically discrete parts. A learner who demonstrates competence in all the components of an activity is assumed to be competent in that activity. In contrast, entrustment relies on the informed but ultimately subjective judgment of more experienced and knowledgeable supervisors. And it's this judgment, and not the checklist, that decides a learner's need for supervision in carrying out an activity or an EPA in its entirety. And competency is thus inferred from this decision. So what linguistic forms are best suited to honoring the subjective judgment of clinical educators in the context of formal assessment? And the answer, as I've suggested, is not a simple one. And I want to illustrate the problem with an example and to suggest that part of the reason for the problematic uptakes of the kind we see in this example lie in our inclination, at least in contemporary Western higher education, to privilege explicitness and, moreover, a certain kind of explicitness in assessment. Now, I hasten to add that I'm not anti-explicitness. I think seeking explicitness is in many regards a very reasonable thing to do. So spelling out norms for evaluation and explaining how learners are or are not meeting these, that encourages fairness and accountability. Explicit norms help to anchor necessary discussion and revision of our collective expectations, and they help to support consistency across contexts. But while explicitness certainly seems to be an important contributor to transparency and shared meaning, it's by no means a guarantor. And a guarantor seems to be what we really, really want, we would really prefer. We look for language that renders our official documented criteria empirically verifiable, stable, and determinative. And aspects of competence that exist beyond these listed observable behaviors that are encountered impressionistically, by feeling, by gut, that might be evaluated differently under different circumstances. They can't be interpreted separately from the complex of knowledge and beliefs and experiences that are particular to an individual assessor and his or her community of practice. These are things that we try to avoid in language of formal assessment. In other words, what often is considered most desirable in assessment is an explicitness that minimizes subjectivity. So this is an excerpt from an EPA observation template that's offered as a resource for medical educators by the Canadian Royal College of Physicians and Surgeons. They seem to come up a lot. And they have been, as Lorelei mentioned, involved in implementing CBE across the country. Now, my intention is not to single it out as problematic, but I want to use it to illustrate some of the challenges that are involved in codifying subjective and often tacit entrustment decisions in a context that foregrounds objective and explicit assessment. You'll note that the concept of entrustment is invoked here, but it's not explained. And that's significant because entrustment is certainly not new to everyday practices of medical educators, but it is a relatively recent innovation in formal assessment. And I have two further observations to make, both of which suggest that it might be difficult for users of these forms to, at least from the form alone, know exactly what is being asked of them, what is being sought with an entrustment scale. First, the language of the scale maintains an objective quality, and secondly, the function of the scale, particularly in relation to other evaluative elements there, is not made clear. So with regard to the first point, individual milestones on the form are either achieved or in progress. And determining that a learner has achieved a milestone is, of course, an interpretive act, but a checklist format reinforces the impression that what is checked off is demonstrated fact rather than a subjective reading. The checklist isn't prefaced by any phrases with personal pronouns like, in my estimation, or I believe that, ... And the entrustment scale could be said to project the same objective quality. It documents what happened during the activity. So for example, I had to prompt, rather than what led to the prompting, namely the assessor's at least partly subjective sense that if she didn't intervene, something might go wrong. The scale doesn't employ effective language like I was uneasy at certain points and I sensed that I needed to prompt. It's not that we can't mentally fill in phrases like that, but by framing entrustment in the language of objective reporting, the subjective aspects of risk-taking that are inherent in entrustment are not acknowledged in a form like this. The second thing I would point out is that it's not clear how the scale relates to other evaluative items on the form. In the absence of such information, the scale risks being read by users not as a complement to, but as a summary of the checklist below. While the discrete milestones in the checklist can and should inform the holistic assessment of requisite supervision levels, they are not a proxy for it. But without such clarification, the assessor might simply assume that once the milestones are achieved, they should add up to a check mark beside the statement, I didn't need to be there on the entrustment scale. Now, we know that the checklist is a necessarily incomplete articulation of competence. Entrustment was intended to address exactly this by tapping into the rich but not always easily expressible language or knowledge that assessors develop about learners. Although the checklists represent a very sincere effort on the part of the community to spell out expectations of the profession, they do not and they cannot represent the full complexity of professional judgment. Now, it's likely that in most cases, the checklist of milestones and the entrustment scales will square, of course. And in cases where there are discrepancies, it's also likely that additional comments in the box below will explain these. So there's very little indication of what might be lost in terms of evaluative complexity in this particular iteration of the entrustment scale. But what if we were to ask clinical educators how they felt about the way the form represented the learner? What kinds of things might they say were missing from the picture? Might these absences ever matter enough to create a sense of unease? Might an assessor feel coerced by the language of the form to indicate entrustability when they don't really feel it in their gut? And what about if objectively recorded evidence, if all of that points to competence, but the assessor somehow doesn't sense that they can entrust the learner quite yet with a given EPA? What should take precedence? The language that welcomes expert judgment in the context of assessment practices that also need to provide for transparency and consistency, that requires further exploration. Future versions of entrustment scales might be modified to include more personal or effective language. They might require narrative elaborations to accompany an entrustment scale. And insofar as subjectivity also encompasses the sociocultural, the scales might also be tailored to reflect the spoken and the unspoken understandings of the specialist community to which the assessor belongs. Then again, maybe we don't need more or better language. At present, entrustment scales are fairly terse affairs, and it may be that their lack of elaboration is a strength insofar as it acknowledges the frequently tacit nature of expert knowledge. But the extent to which we would be comfortable with a bare bones scale and nothing more, that's doubtful. Modern assessment systems tend to rely very heavily on documented justifications. And so some further textual elaboration is likely to be called for. And so the question remains whether and how we can devise forms of representation that can satisfy such systemic requirements and yet embrace as trustworthy the sometimes only fuzzily expressible knowledge that underpins assessors' judgments. Thank you.
When I started on faculty in internal medicine at my institution, I frequently would serve as a ward attending on the inpatient internal medicine service. And this was just before the time that we were all introduced to the language of entrustment. But I had in my head that I would spend the first couple of days doing what I thought of as diagnosing each of the learners on my team. I would have a senior resident and 1 or 2 interns, postgraduate first-year trainees, and 2 students. I would receive a sign out about how each of these learners were doing from the prior attending, and then I would start to work with these individuals. And sometimes, surprisingly, I would notice that my impression of one of the trainees, particularly the senior resident, might be different than what the last attending had experienced, even though I was pretty sure that resident hadn't changed much in the past week. And even more concerningly, sometimes I changed my mind over the days, so I disagreed with my own assessment of this resident, and I wondered how that could be. I believe that is due to the complexity of entrustment. We don't make entrustment decisions or judgments of entrustment in a laboratory setting or a controlled simulation environment. We're making these decisions in the very messy, dynamic clinical space. And I think we oversimplify the process of entrustment if we consider it a go, no-go decision or a yes-no decision. We just saw in the last presentation from Anneke how this is thought of on a continuum, and it's a quite dynamic continuum that changes as different clinical scenarios arise. In my doctoral work, I thought with our team about what goes into a decision to trust or not trust a trainee. We start with the trainee thinking that an entrustment decision must relate to their knowledge, their skills, their behaviors, and attitudes. But an important aspect of trust as well relates to the supervisor. Some supervisors may be more inclined to trust other people, other trainees. They may have more or less clinical knowledge that influences their ability to step in or step back in a clinical scenario. And of course, the task at hand will influence the degree to which we trust a trainee. We may trust them more if they happen to be presented with straightforward admissions versus more complex patient scenarios. And as we think about sociocultural theories of learning, looking at the framework of workplace learning, we appreciate the importance of the rich context in which all of this is happening, with many other team members, interprofessional colleagues, the busyness or not busyness of any given day. We also were very interested in the relationship between the supervisor and the trainee. As we increasingly think about bias in the work that we do, we may begin to appreciate how we might be more likely as supervisors to trust a trainee who looks and behaves like us. Together, these two individuals need to negotiate what are the expectations and how are we going to interact. And if that process happens quickly and goes well, there's more likely to be trust on the part of that supervisor about that trainee. So based on a literature review, we began to feel that we were starting to unpack the complexity of the process of entrustment. We then undertook a study interviewing internal medicine faculty about their experiences of the process of entrustment working with resident physicians. And as you can see, they had a lot to say. On the left of the slide represents how they described to us starting to think about entrustment. Some of them said, well, I compare this resident to a typical resident at this level, or maybe I compare them to the last resident I worked with. Others said, I jump in quickly and make sure I observe something, and that defines my starting point. Others said, well, I check with the patient, which I thought was a pretty surprising and very nice way of beginning to think about entrustment. And then others had more extreme versions of starting points. Some said, well, I always start with high trust, and then that resident needs to either hold that position or work their way down if I'm not satisfied with what I see. And other attending physicians said, I start with no trust, and they need to earn it as we work together. Then, through the process of the coming days, their entrustment was influenced by the factors shown in the center of the circle, the task, the context, the relationship. And we heard from these supervisors about various accelerators and barriers to trust formation. Accelerators of trust formation were opportunistic and were idiosyncratic. If we had a patient that was quite sick, but just at the leading edge of that learner's ability and knowledge, and they were able to manage that well, then they'd really prove themselves, and an attending would say, now I felt I could trust that resident the rest of the month. In other situations, we heard about barriers. For example, if the census was too low, if we didn't have many patients, or if the census was too high, or if we had a struggling intern or student on the team, all of those factors took away my attention. And so usually those things delayed the attending physician's development of trust, but sometimes it accelerated it if those other factors kept the attending so busy that they had no other choice but to turn some responsibilities over to the resident. On your right of the slide, you see what happened when trust formed, and it usually did among the attending physicians at these two institutions, working with a resident over a period of 2 to 4 weeks. They said that when they did feel trust in this resident across a range of clinical scenarios, a lot of good things happened. The supervisor felt like now I can take a step away from doing a lot of in-person or backstage supervision and really focus on my teaching, on developing other members of the team. They noticed, these attendings, that when they trusted their resident and it was clear to the resident that that entrustment existed, that the residents seemed to accelerate their learning. Residents were very motivated in these circumstances to lead the team and take on more of an attending-like role. And the whole team functioned higher in what's been described as a pace-setting team. The attending would say, we were the team that other teams looked at because things were going so well for us. So what are some of the additional complexities in that very already complex entrustment process that we're continuing to see emerge in the literature? Entrustment may differ across specialties. The original language about supervision came from procedural specialties, and in many ways that can seem like a relatively simple place to think about entrustment. For example, if a trainee's doing a procedure and the supervisor is right next to them, the supervisor can be assessing, gee, am I needing to take that instrument from the trainee, or am I needing to guide them in the way that they do this procedure? But it's not that simple even in a procedural field. For example, in OBGYN, a study by Van Loon showed that only 20% of the variables or the components of an entrustment decision were related to that trainee's technical skills. So we can think, what is that other 80%? Maybe it's more similar to non-procedural specialties. And in the cognitive focus fields, like internal medicine, like family practice, there's not usually a discrete procedure that's the focus of the entrustment decision. One of the challenges in these fields has been what exactly is being entrusted. For example, in the hospital setting, is it the admission or the discharge process, or is it the entire course of the hospitalization with all its ups and downs? Or in the ambulatory setting, is it one patient's visit, or is it the longitudinal management of their diabetes or heart failure? These questions puzzle educators who are trying to think about how much they can entrust a trainee if they're not even sure what the task is that they're supposed to be entrusting. And we've discussed anecdotally in preparing for this panel that entrustment decisions may be different in the field of pediatrics, where perhaps with the health of children at stake, attending physicians may have less inclination or less propensity to trust as quickly as physicians do who are supervising the care of adult patients. And in my last slide, I'll ask you to consider how the level of training of the learners with whom we work or the level of experience of the supervising physician may influence the process of entrustment. With trainees, we work with students and we work with postgraduate residents. At the level of students, we did a study at our own institution asking supervising physicians and students how they defined entrustment of students. And the students spoke loud and clearly that they viewed being entrusted the optimal scenario as a supervisor, either a resident or a faculty member, knowing what they needed to work on next, finding an opportunity for them to do that, inviting them into that opportunity, and then staying with them to provide coaching and support. And all of that happening after they discussed in advance what were the expectations and how am I as the supervisor going to guide you. Students felt when they were given a lot of autonomous opportunity to see a patient that presented a challenge for them as learners, that they were worried if they were being given too much responsibility to the point that it could jeopardize patients' care. In contrast, as you heard from Dan earlier, the language that residents typically use or supervisors use thinking about what residents want with entrustment is usually centered around the goal of autonomy. And in many ways, that's a good thing. These physicians are closer to being able to practice without supervision, and they are stretching their muscles around how self-directed they can be in advancing their learning. We hear from residents when we study entrustment that they want to be independent, but they also like knowing that the supervisor's available, or perhaps doing some backstage supervision, watching through the electronic health record. And the final point I'll ask you to consider is how the supervisor's own training level influences their thoughts about entrustment. When we looked at our data around how supervisors think about entrustment, we saw interesting patterns that suggested variability in how supervisors think about this based on their own clinical experience. And when we interviewed residents, we found that they confirmed this impression. The junior faculty who were supervisors close to the time that they had finished their own residency often lacked full confidence in their own clinical skills. So they feel unable in many cases to trust a resident to manage a patient independently because they as supervisors don't really know what's going to happen with that case. They're not yet ready to say, I can anticipate where the trouble spots are going to be. So as a consequence, they stayed more hands-on with their supervision because they wanted to be more hands-on with their patient management. These junior faculty also described using a very rules-based, sort of one-size-fits-all approach to entrustment, having less ability to flex it based on what they were seeing in the resident's performance. As we looked at the entrustment process for more seasoned attending physicians, we found that they felt more able to adapt their supervision from more to less based on what was happening with the patients, with the team, and what impressions they were forming about that resident. And with the most seasoned attending physicians, those who'd been at it for not only years but decades, we heard that they took what was perceived by residents as a pretty hands-off approach, but these residents nonetheless felt supported. These were attending physicians who viewed entrustment in the most holistic way. They weren't thinking about the steps involved in managing a patient problem. They were thinking about the whole thing as one package. And they usually took a fairly hands-off approach, but had a very nuanced judgment that they had difficulty describing, but that signaled to them when they needed to step in and be more hands-on to support a resident who needed that extra patient care support to both learn and ensure safe patient care. So with that, I will stop and turn it over to our next presenter. Thank you.
So good afternoon, everybody. I'm going to switch gears a little bit here. So you've heard a lot about all of the blind spots. And I guess what I would like to talk about is how these blind spots have actually coalesced in some way and clouded our current research that we have tried to do on EPAs. So we hoped for a new way of seeing. Dan and I were co-investigators on this general pediatrics EPA study. A fairly large study. 22 residency training programs have been involved, and we thank every one of them. Almost 2,000 trainees. We engaged in a 3-year longitudinal study, and we had 17 general pediatrics EPAs that we were studying. Our first step in this study was to send out a sort of a priori survey before we actually started to collect any longitudinal data. This was sent to the clinical competency committees to gather expectations of which of 5 narrative descriptions of performance aligned with initial entrustment, which we've heard here has been defined as originally by Olle and Cate, as ready to practice without supervision. And the other piece that we wanted to actually get some expectation for was where they would be at the time of graduation or program completion. Now, I'm just going to take a minute to describe to you what these narrative descriptions were. So you've heard about supervision scales. We used a modified scale, very much like the ones that you've seen here, but we did one extra thing, and that was we took each of our 17 EPAs and we mapped them to the competencies and milestones that were most critical for making an entrustment decision. So we did the mapping very judiciously. Once we did that, we actually created a matrix where we lined up the narrative descriptions of the milestones across each row next to the competency that they belong to, and then basically dropped a perpendicular down each column that represented a performance level. So in the end, when you drop that perpendicular down a column, you wound up with a description of each competency at that level of performance. We synthesized those into what we called a narrative. So it was a clinical narrative. And if you thought about that, what it created was a picture of performance at that particular level for that learner, for that EPA. And that actually was done so that we could create a shared mental model. So going beyond just whether this learner was entrustable or not entrustable or what level of supervision they required, we wanted to actually get more of a shared model of an anchor by actually describing the learner behaviors. And that's what we asked the CCCs to tell us when they were ready to entrust a learner for the first time, initial entrustment, or when they were entrusting them for purposes of graduation, where they were at graduation. What would their performance actually look like? And then we tracked the actual performance levels semi-annually over 3 years. So this first a priori survey of expectations of performance at the time of initial entrustment and at graduation, and then tracking actual performance semi-annually over 3 years. Well, so here's how it turned out. A little bit unexpected. So for all but the 4 EPAs illustrated here, so for the other 13, the expectations of performance at initial entrustment and graduation were aligned. And that's actually one thing that we certainly expected. That was for 9 of the EPAs. For the other 4, we found something that again was expected, and that was that initial entrustment occurred prior to graduation. And this, again, all made sense. However, for the 4 EPAs that are displayed here, we were pretty surprised to see that the clinical competency committees, or CCCs, expected residents to become entrusted after they graduated. Now remember, entrustment is defined as readiness to practice without supervision. So that was a little bit concerning. And if you look at the graphic here, you can see that the darker dots represent expected for entrustment, and the lighter dots expected for graduation. So the opposite of what we would expect. The data on this slide represent actual performance level. And again, this was using the narratives assigned to trainees at the time of entrustment. And if you look at the narratives, they range from a numerical value of 3.5 to 4.5, which, if you actually align those with the Dreyfus model of assessment, it puts trainees in the range of competent to proficient at the time of entrustment, based on the narrative descriptions. As we further analyzed the data, we were pretty hopeful that maybe the clouds and the fog would begin to shift. We thought, well, maybe if we dig a little deeper into this data, it's going to make more sense. Here we see the overlay of the narrative performance levels at the time of actual entrustment. So those are the green triangles. This is what the CCCs actually reported based on the narratives at the time of initial entrustment. This was based on trainee performance. And if you look at that against the expected narrative performance levels at initial entrustment, which is the brown or the darker circles, and at graduation, which were the tan circles, it's interesting to see that expectations of performance at graduation were the lowest. Expectations at entrustment were a bit higher, and for all but EPA 14, which represented quality improvement, actual performance is even a bit higher. For EPA 14, the actual performance greatly exceeded expectations for performance levels at both initial entrustment and at graduation. EPA 14, as I said, represented quality improvement. And that was the one that program directors and clinical competency committees had the least expectations for, with many opting to graduate residents before entrusting them. And yet, the data show that the average performance at the time of entrustment was just shy of 4.5, which is between someone who is proficient and someone who is expert, if you use that Dreyfus model. So, trying to see through this data really came down to this. The clarity that we hoped for was pretty elusive. I think that we sort of remained a bit cloudy and foggy at the end of the data analysis. And as you can see here, we have a lot of unanswered questions in the wake of our analyses. What does it mean to have CCCs expect residents to graduate before they entrust them with unsupervised practice? You know, when expected performance is low, what does this say about our curriculum, our faculty, our trainees? When expected performance is low, but actual entrustment is limited to narrative performance at levels 4 to 5. Wow, is this a mixed message? And how do we set performance standards or thresholds when empiric standards differ from desired standards that would meet the needs of the populations we serve? So at the end of the study, we wound up with many more questions than we got answers, to be honest with you. And I'm going to end with this quote by Ron Bolan that says, "We love fog. We have to love fog because it shifts old anomalies into the elements surrounding them. It gives relief from a way of seeing." And now I'm going to let Professor Olle Cate answer all the unanswered questions that I left him with.
Thank you, Carol. I think that was a misunderstanding. So I was hired to be the discussion, to add more questions and not give the answers. So as a discussant, you like to have the bird's eye view. So just say something about all these previous presentations, and if you think of a bird's eye view, you're watching through the clouds. That I took your clouds, Carol, and just look at from the top, from an airplane, with the desire for every way of seeing. Of course, every way of seeing is a way of not seeing, but we want to see everything, actually. So see how far we get. Just brief, stirring up your memory of what we talked about. So Lorelei talked about interdependence as a norm. And let me take the opportunity to give a confession that may surprise you, Lorelei, or even the audience. The word independence, as a part of the definition of EPA, is never meant to be independent of other persons. So independently executable is an EPA that is not dependent on another EPA. That was the original. And I acknowledge that people start reading that and say, well, this is independent. So he must have meant as an individual, not dependent on other people. And it's interesting that I'm actually working on a paper now about interprofessional EPAs, which is a pretty complex concept, I can tell you that. But what's clear from all we know, and also clear from the very presentation today, actually by Angstrom, is how interdependent everything is in healthcare. That holds for EPAs too. So interdependence as a norm, I think I would really support that too. I'm going to focus on autonomy. Dan, I liked your reference to self-determination theory. And those who know self-determination theory know that those people have Rich Ryan and Edward Deci. And I was recently at a conference where Rich Ryan, one of the originators of that theory that holds that there's three elements that support intrinsic motivation of individuals, which is the feeling of being competent, autonomous, and related. And he actually showed a slide that I tweeted because the slide said what autonomy is not. And it's so important to think that autonomy is not things like selfishness. It is not that there's no rules. It's not complete freedom. There's a sense of choice that you could do. That's the most important element of autonomy. And I think you stress that well. And then trusting the entruster by Anneke van Enk. I think that was your theme. And I have had the privilege to have several discussions over the year with Anneke about this topic. And we really came to appreciate that. Expert judgment is so important, and we must realize that expert judgment cannot be captured in completely captured in any scale that we can think of. The harder we think of scales to capture everything that's important in expert judgment, as we also know from patient care, but it's also about students and individuals. The longer we think of it, the more we are convinced that expert judgment is important and it cannot be captured in things that can easily be translated to skills and even sometimes language at all. If a surgeon knows this student is not ready to do this individually or unsupervised, we would say, is not always able to explain why, and it is still important. If you only revert to checklists, we're throwing away the baby with the bathwater. So trusting the entrustor is important, because if we have an educational system, we need to rely on our faculty members that take entrustment decisions. We need to rely on their judgment to inform us as CCCs to make the overall summative entrustment decisions. So we need to entrust the entrustor. Then the complexity of entrustment decisions, and we keep thinking a decision may be made, and this is probably reflects where the student is, and then suddenly we realize this was a situational decision. It may be different tomorrow, it may be different this afternoon. There may be so many things that are involved in our taking this decision. It's interesting to think about the dialogue with the student too. If the student would think, well, they trusted me to do that yesterday, why would they not trust me to do that today? And I think the dialogue is important, because students must also understand that a decision to trust at moment X does not mean that at moment Y the same decision could be taken. But ultimately, we have to move into that direction, because at the end of the day, there is a license. There must be a moment that we provide that license to individuals and say, from now on, you are a mature physician or other health professional, and we must be able to trust. We must be able to say to our patients, you can trust this person. That's our educators' responsibility. So forcing educators to think about entrustment decisions is so important. And it's more than just evaluating a learner. It's more than looking back in retrospective scales, how much supervision did I provide. That's not enough, because you can reflect that. But the most important question is, do you think this person could do without your help tomorrow, looking in the future? And then finally, the validity of expectations, or the validity of things that we think based on the data that we have, do they reflect reality, and do they reflect the decision that we can take? And I think I'm happy with the studies that you do, because we need those studies to make sure that people that the best that we can, when they provide them a license or a certification to work unsupervised, that is as valid as possible. I can cite one thing that you might find interesting. We did this study. One of my PhD students was a veterinary student. You have to realize veterinarians do not go to postgraduate training, most of them. That's an exception. So they are supposed to be ready for unsupervised practice right the day after their graduation, after 6 or 7 years, whatever length their training is. And I can tell you, and that will not be a surprise, that if you are a large farm animal veterinarian, you might have to do a cesarean section. And if you're lucky, you've done 2 of them, or less lucky, 1 of them, or even less lucky, none of them. And you're still expected to do that. So our study, actually, one of our study in this thesis is about how much supervision do people actually require after they have been licensed. And it's quite acknowledged, actually, that is important. So even if we make entrustment decision, even summative entrustment decision, even license, it does not mean that there's never no supervision in demand or required. We have to think of that. It is an important marker in development of learners, but does not mean there's always a lack of need for supervision, or however you would call that. So now, before we open up the discussion with the audience, I would like to pose just a few questions and have you think as an audience about these questions. We're still in the airplane looking down, right? So many of you just arrived in Vienna. And did you trust, when you went into the airplane, the captain when flying to Vienna? Just think of it. Or before you embarked, did you consider any entrustment? So you probably did not. So ergo, so what do we conclude from that? That entrustment in health professions education requires some supervisory volitional choice. That means if we cannot choose, if we have no option to choose, entrustment becomes something very different. So if you step into the airplane, there's no other way to get here, you'll have to trust. And it is trust. It is trust. But it's not an entrustment decision that you have a choice not to take that decision. So then there's not an option to withhold that trust while the course of actions are not critically hampered. So if you have a learner, when you take that decision or not take that decision, somebody else must do that. So here's where it makes a difference. We have to remember that. So entrustment decisions are superfluous and useless if there is no choice. And then just remember, if you have had a family or still have a family or young kids, think of your most trustworthy kid and you would think, I would trust this kid always. And then think of this, would you have trusted him or her with driving your car? Till a certain moment, you probably would have not, even though you would consider your child trustworthy. So entrustment requires an object that has limits. So not every trustworthy person can be trusted with everything. Just remember it. Then think of the most trustworthy person you know, and it would hold for me, but it would probably hold for other people too. Is it your spouse? Now you think, the spouse is the one person that I can trust most. And then think, why would others not consider your spouse the most trustworthy? And you not theirs. So we have to think entrustment requires a trustor and trustee relationship. A trustee may not disappoint you. Sometimes may disappoint somebody else, or vice versa. So there's also reciprocity in trust. And finally, when I say entrustability, what comes to mind first? Just think of it. Is that something that says about a learner or an activity? When I use that word the first time, I meant it to signify activities that are entrustable, that has the property to be entrusted. And calling learners entrustable or not has a risk. It can lead to scales that are called entrustability scales that move away from the actual supervision decisions. That's the reason why I have a slight preference to not talk about entrustability scales, but entrustment supervision scales. What you don't want to end up with an entrustability scale is not essentially different from a proficiency scales. And I would actually give a suggestion to resist that inclination, because entrustment are discrete decisions that must be taken. And it's not something just open in the air. It is actually moving towards a decision that must be taken. Well, this is the last of the series. Can an entrustment decision be justified for a less trustworthy learner? So, does it ever happen? Of course it happens. When the service and the context require that the best qualified available individual acts to prevent critical adverse events. Just think of the airplane again. So is there somebody who could help this patient, and who will push the button? Is it the medical student, because it's the highest qualified person in that space? Or is it somebody else? Sometimes you would have to trust even with somebody who has not the qualifications to be trusted in a different context. So complexity of context can urge ad hoc entrustment decisions. And I would warn against summative entrustment decisions. That's a detail, but at that moment, you might sometimes want to ask a person to do that who may not be qualified. And to end with a slide, since we're talking about language, there's a suggestion that I show you something that comes into entrustment decisions that we not always realize. We have to understand that entrustment decisions, it's more than a qualification of skill and knowledge. When you take a decision, you're taking risks, and you're vulnerable. With a student who does something wrong with a patient, it will probably bounce back on you. So you have to think what comes into entrustment decisions. If we ask clinicians what are important features of students to show that, they can be grouped into 5 groups. One is agency, a level of self-confidence and proactiveness towards work team safety, reliability as conscientiousness, predictability, accountability, responsibility. Then it's integrity also. It is truthfulness, benevolence, patient-centeredness. It is, of course, capability. If you think of specific APA, there must be specific knowledge, skills, experience, awareness, oversight sometimes. And there's humility. Humility says that a person is willing and able to observe their limitations, willing to ask for help, and receptive to feedback. And lo and behold, if you see those letters aligned, you end up with a rich entrustment decision.
So we'll spend the rest of the time taking questions from the audience. 2 things as people come to the mics. If you are tweeting about this, please use the hashtag #EntrustWords so that we can all follow the conversation online and here after the session is over. Second thing, we will commit to 1 or 2 people answering questions. We hope that you will commit for us and for the whole audience to ask a question and not tell us about sort of your personal context so that it can apply to all of us. We have mic 3.
Hi, this is wonderful. Thank you all for your contributions. I'm thinking about what a few of you have mentioned with regard to risk and the relationship that any given supervisor has to how they live their lives vis-a-vis risk. Some people are risk averse, some people are not so risk averse. And then in certain very litigious societies, such as in the US, we are often, as supervisors, living in fear of what will happen. Just a very quick example, in my clinic, a patient's family sued, and a not-so-wonderful lawyer involved every single preceptor who had ever signed anything in that chart. As you can imagine, that greatly changed the scope of entrustability among everyone. So my question is, what can we do? Is it faculty development? Is it helping people to get in touch with their own relationship with that risk and with their anxiety around it that could help people be better at making these entrustment assessments?
This feels best to question to Karen based off of her, I don't want to put her on the spot.
That's a great question, and I would say that while it can feel like a safeguard to think, well, I would just, as the attending physician, check everything and do everything, I can say from personal experience and also from our study data that it's actually not even possible. So as we deal with the fact that we may live in a litigious society, I think that we also realize that if we are able to make informed judgments about when to check something or when to supervise, and to think about what tools we have to do that in a way that the resident sees or that happens without the resident directly seeing, we may find that the supervisors would be able to target their efforts rather than a blanket approach that actually wouldn't be possible anyway.
Microphone 2.
This is Debbie Jarsma from the Netherlands.
I'd really like to thank the speakers panel for a thought-provoking session. And I was wondering, maybe a bit odd topic in a sense, but you know, Olle and Cate and Fede came up with this idea 12 years ago. It took on a life. If you look in the Netherlands, all the program, the postgraduate trainee programs, they all are now turning into the EPAs, thinking about it. But in my opinion, it becomes simplified. It doesn't have this sophistication of thinking. And I think what Olle was saying, you know, I don't want it to be simple like that. I wanted to have the dialogue. I wanted to have this. And now you're, you know, in all your empirical research is saying it's so much more complex. But what I see in practice, it is checklists. It comes down to checklists. And all that dialogue is not there. And I see the struggle, the same struggle with the competency frameworks and competency-based education. So I was wondering if you could reflect on this movement, also this historical way of how we do things. And could it also be that if we come up with a new innovation next time, we first look at authentic practice and what's happening there and what the complexity is, and then come up with ways to actually change practice? Or maybe I'm seeing the things wrong. I was just wondering.
Yeah, Olle, Carol, this feels...
What I can say actually at your last remark, I think the idea of using EPAs is basically actually stirred by the idea of what happens in practice, what happens on the work floor. So, and I do acknowledge and we're all medical educators, many are experienced medical educators, and we know change is not something that you can simply do very easily. I do think that people are thinking about things, and even though it's not easy, and I'm definitely sure everybody's pressed for time, they don't have much time for observation, at least it happens much more than it happened in the past. So I think it's the first step, and I'm definitely aware of how different in the Netherlands are, how different specialties approach that differently. I'm not as pessimistic. I know that pediatricians, for instance, are very, very thoughtful in their process of doing this. And I think there are very good examples too. And I hope they will serve as examples for other domains too. The only thing we can do is keep explaining that some things are not as easy and require more thought in conferences like these, and hope people take them back home and use them in faculty development. Do you also agree that when we try to keep explaining, it's really about language, and we're still figuring out what our language is? It's a co-construction constantly, and my experience is that our doctors really like a clear answer, but it's difficult to give them the nuanced answer because they want to get on their practice, but they also experience that practice is complex and messy, like Karen and Lorelei were explaining.
Yeah, Lorelei.
Thanks, Debbie. You put your finger on exactly why we organized this symposium, because we use the language of entrustment. I mean, your point about your intended use of independently, as contrasted with the way it's been taken up, I think this kind of critical reflection of what are we actually doing is really important, because the way we use the language will drive what we do. It's sort of my fundamental point all the time from a rhetorical perspective. But two other comments I wanted to make. I mean, it's human nature that the more things change, the more they stay the same. We will resist change, and I think our tendency to take up words like independence in the ways we've always used them in assessment is part of that kind of human nature to just call it something else, but really just keep doing what we're kind of used to doing. And we're really trying hard to be reflective about that, I think, in Canada around competency-based medical education, so that we just don't end up doing what we always did before, but putting a different label on it.
Yeah. Thank you, guys.
Yeah. Microphone number 1, and then we'll swing back over to 3.
Ian McPhee, I'm a family doctor in Ontario, in Canada, and I'm just wondering, the big thing that sticks out to me is when we don't trust the entrusters. What kind of things do we need to put in place so that we can validate their descriptions. I mean, we all know excellent clinicians that are absolutely horrible teachers.
I guess that's me. I don't know what we can put in place exactly. I want to say a better entrustment scale, but I'm not sure that's exactly the answer that's required. For me, so far, what I've seen is that we're trying to introduce something that's counterintuitive to the way we've been doing things for ever so long. We're trying to introduce something that's counterintuitive to administrative needs and systemic needs that call for transparency, that call for accountability. That's become a huge movement in higher education. I think particularly in the UK, it's become, it's a huge talking point now because everything has to be accounted for, everything has to be explained and itemized. And in the process, we lose important skills, knowledge, insights, but at the same time, we need to balance it with this need for explicitness. And so I'm not quite sure exactly how that will shift until we're clear about maybe that language will not deliver specifics and certainty, and that we need to, I don't know, maybe to learn to use language differently or to think about how we use language differently, that we don't expect that it's going to pinpoint and give us certainty, but that we need to use it more creatively as a resource, more flexibly as a resource. Lorelei, I don't know if you want to say something about that.
Well, so I guess I will make one general comment, and that's that, you know, I've actually watched the CBME movement over the last 20 years, and we're clearly not where we need to be or where we want to be. But I have to say, we have come a long way from what medical education was like when I was a program director in the 80s and 90s. And I think the fact that we're sitting in this room having these discussions is a real testament to the fact that we're moving in the right direction. And there's a long way to go. I think your question deals a lot with issues around faculty development, and we have not tamed that beast yet by any stretch of the imagination. I think a lot of it is because we have aspirations of, you know, doing so many things when what we really need to do is reality test and say, which faculty need to know what? Let's make it doable. Based on your role, what do you need to know? And I think that's something that might be helpful. And I guess I would just encourage people to compare where we are now to where we were then, and not to some ideal that doesn't exist and never has existed. And I think people will appreciate the great strides that we've made and not become disillusioned. I think part of the reason for our data being difficult to interpret, shall we say, is the fact that many of the faculty that we are asking to observe trainees right now were not trained in the competencies that they are now being expected to observe and assess in residence. And I think that's a huge barrier to understanding how to assess someone when you yourself don't really understand what that competency even involves. I mean, do all faculty understand systems-based practice or practice-based learning and improvement? And I think that's why our quality improvement EPA came out the way that it did. Faculty do not understand the conceptual framework. They were not taught it. So how are they expected to assess it?
Yeah, so we'll come to microphone 3, maybe for 2 questions, and then we may be done.
Reinhard Kremke, a pediatrician from Amsterdam. Thank you very much for your presentations. The perspective from which EPAs are used so far is particularly the stepwise or maybe gradual qualification for residents to practice a medical specialty independently. The point I would like to raise is, how do the panel think of using APAs from the perspective of maintaining or recertification as a specialist? Like in the Netherlands, I'm a consultant pediatrician. I have to visit congresses like this, and also pediatric congresses, to get my accreditation, CME points, and then in 5 years, as I practice, I may register again. Aren't we coming to a situation in which we should consider using EPAs for lifelong learning as our specialty evolves so rapidly?
Yeah, so I know that people on the panel have actually done some thinking about this and writing about this, but maybe I'll take it because I've done some discussing with them about it. Yes, I think that EPA should cross the continuum, that the idea of entrustment should cross the continuum, and that includes going into practice. And some of the questions that this raises is, how long is an entrustment decision good for before it expires and needs to be sort of like, sort of like recertified that you're entrusted for that. I think that I can speak for at least some of the people on the panel I know would agree with this. I think then the next question is, are all EPAs created equally? Can some last a little bit longer? Should some expire a little bit sooner? Getting into some of Karen's things, how much does complexity of the task go into that? Also, how much does your current practice play into that, and whether you're doing, sort of more in that area or less in that area? These are big questions that I think are important to be talking about, because yes, we should go across the continuum. Maybe we'll take the next question at the microphone 3, and then we'll end there.
Hi, thank you guys so much for what really was a very clarifying, I think, presentation, and something that can often be nebulous, or at least talked about in a very nebulous way. What struck me while I was sitting there listening was that it seems to be clear that strict objectification of these milestones sort of do a disservice both to the learner and to the idea of competency-based medical education. My question is there a role for qualitative data? And if there is, how do you see that being a part of this? Because that's certainly something that's so difficult to include in this, and how do you even codify qualitative data?
Yes, absolutely. Does someone want to follow up on that?
I think any one of us could follow up on that, but I would answer there's absolutely a role for qualitative data, and there's some nice emerging research helping to instruct us about how we would make sense of that text-based data. We have a whole infrastructure for making sense of numbers-based data, but we're really quite young as a domain in terms of dealing in a sophisticated way with text-based data, but there's some really nice work, Schiffer Ginsberg's work on, how people write their text-based qualitative comments on trainees in a kind of a code that, by the way, everybody can decode, but it's in code anyway. I mean, text-based data is no more self-evident than the numbers are, but there's some really nice methodologies emerging for helping us do that. I think the major limitation is not methodological, it's resource, both the faculty resource time to produce meaningful text-based data, and then the division or the department's resource time to actually meaningfully use it.
Yeah, I'll just leave you with an anecdote about this. So the study that Carol presented that we did together, actually we've done some follow-up interviews with the 22 sites, and the one site that uses entirely narrative comments qualitative assessment data, actually it sure seems like had the least issues with implementing and assessing EPAs, which I think is something interesting to chew on. So with that, we are at time. Thank you all for coming to our symposium.